Hi everyone, welcome to this case study. My name is Marvin, and today we're going to go through HIV and some antiretroviral drugs that we use to treat it. This is going to be quite a quick talk, so we're not going to jump into too much detail, but I'm hoping to cover the most important points, which are firstly, what is a retrovirus? How does this kind of virus get into the body? How does it actually cause the damage that it does? Then specifically about HIV, what are the kind of the enzymes, the particular targets that we could use to develop drugs and for which drugs have been developed. Then I want to illustrate the clinical, the sort of more um, realistic features that you might see in someone in the clinic who has HIV or AIDS. And then we're going to discuss how antiretrovirals can be used, how they're used, and what they do and how they work. Okay, so on the screen, you should see DNA, which goes to RNA, which goes to protein. Um, the textbooks love banging on about this. They call this the central dogma of molecular biology. Basically, it just means it's very important to know because that's how virtually every living thing and every living organism, um, we start with DNA that gets transcribed um, by enzymes into RNA, which is single-stranded, and that RNA then leaves the nucleus where it's then translated into proteins through ribosomes. So this is the basic order of molecular processes within our cells. And what retroviruses do quite weirdly is they actually go backwards, which is really strange in biology terms. And so they start with RNA and they have a special enzyme, which they have and we don't, called reverse transcriptase, which turns the RNA, transcribes it in reverse into DNA, and then from there, a virus will hijack a cell's machinery, if you like, and it will go through the DNA, then back to RNA, and create proteins of viral structures, which then that will be burst out of the cell, and that's how you get spread of the virus within the body. More concretely, we'll go through this step by step. So we have a retrovirus. It's on the outside of the cell. It needs to get within the cell. So the first step is called binding, and that just involves these spiky bits on the outside of the virus. It attaches to essentially the spiky bits on the outsides of our cells, and that allows it to then fuse with the cell membrane, and it can then eject its contents into the cell. So this purple kind of square is called a capsid. We'll talk about this in the next slide. But this capsid contains a whole bunch of nucleic acids and some enzymes. So RNA is released into the cell, which is what the yellow kind of swirls are here. That RNA is converted, is reverse transcribed, if you like, into DNA. Then that DNA is integrated into our own DNA. So this is why one of the reasons why HIV is so difficult to actually cure. Um, in fact, arguably it can't be cured using just drugs because um, it's actually bound to our own DNA. So it can lie dormant for a very long time, causing no problems. And then if it's reactivated, that DNA then produces lots of um, virions, lots of virus particles, and the infection can start again. So anyways, we have the viral DNA. It's now integrated into the host DNA. That is then we follow the central dogma. So we get DNA, we produce RNA and proteins, and that's step 5 there, the replication stage. And lastly, all these components of the virus are assembled and they bud off using the cell's own membrane. They bud off, and now you have a new virus particle which has left the cell, punching a bit of a hole in the membrane, damaging that cell, and which then goes out into the rest of the body looking for new cells to repeat the cycle over and over again. So the HIV virus, I have to say, I have some admiration for the structure of the virus because it's such a simple, um, it's so simple, and yet it manages to cause so much damage and so many problems. Um, so starting from the outside, we're going to work our way in and talk through what each bit of the virus does, which later on we'll see then how each bit, each process, each enzyme, more or less can be targeted by specific drugs. So from the outside, in this sort of light blue, these spiky bits, we talked about the glycoproteins, um, and they have several functions. One of the main functions is just helping it to latch onto our own cells. Then these glycoproteins are embedded within a lipid membrane, which encapsulates the virus. Um, Underneath the lipid membrane, we have what's called a matrix. It's not particularly important. It's just another layer to be aware of. Then here's where it gets a bit more interesting. We have what's called a capsid in red here. A capsid is a set of structural proteins, and this capsid is the function is to protect what's inside the capsid. So once this gets released into the host cell, the capsid stops the RNA and the other proteins, the enzymes, from being broken down immediately. And within the capsid, we then have these three enzymes, which I'll spend a little bit of time talking about because they're very important. We've spoken about reverse transcriptase. It takes the viral RNA, in green here, takes the viral RNA, converts it into DNA. Then there's something called a protease. Actually, let's talk about the integrase first. So the integrase, we have the viral RNA. It's been converted to DNA. The integrase integrates that DNA into the host DNA. So there's no enzyme in the human body that does this process. So it's a unique viral enzyme. In fact, all three of these enzymes are viral, which makes them really, really good targets for drugs because, yeah, this makes me think actually of during COVID, Trump was talking about bleach and how it's really effective at killing coronavirus. This is really, really true. It's 100% effective at killing most, I think all viruses really. The problem is it would kill us as well. It's toxic both to viruses and to human cells, so it's not a good therapy. What's nice about, or not nice, but what's useful about understanding these structures of the virus are that if the viruses have them and we don't, then that's a target that we can hit without damaging all the human cells. And this protease is really important in actually, once the viral proteins have been created within the cell, the protease chops them up into smaller pieces, which then assemble to form the new virus. So if they can't be chopped up, these big, massive proteins, then the virus can't actually spread. That's also a really important target. All right, so a little case study to kind of illustrate what we've been going through. We'll have a 44-year-old nurse, we'll call them S, and they're working in an HIV unit, and they've been taking some blood from a patient, and they accidentally pricked themselves with a used needle. I will just point out that actually passing on HIV through a used needle in this kind of way, the likelihood is really, really low. It's kind of in the 1% or less kind of range, usually. So this is really unlucky because S doesn't really notice. He's in a hurry. He just kind of gets on with his day. Then 5 weeks later, as unlucky as he is, he now gets a really high fever. He's got these really swollen lymph nodes around his neck. He's got sore throat, joint pain, a rash. He thinks it's just a nasty sort of maybe a flu or something. So he stays at home for a couple of weeks and he starts to feel a bit better. But now 3 years later, he ends up back in hospital, this time as a patient, and he's had a chest infection, which is actually found to be caused by a fungus. Now this is really unusual because people with functioning immune systems shouldn't really be getting fungal chest infections. And this particular fungus is called pneumocystis, and it's very characteristic of an HIV infection. So the doctors treating him think maybe he's got HIV. They test him for it, and it turns out he does have HIV. So S is probably feeling quite devastated at the moment because having an HIV diagnosis is very stigmatized, and people don't tend to take it lightly. And a big reason for that is because as the disease was becoming a pandemic back in the 60s, 70s, 80s, there weren't any treatments at all. There was nothing that could be done for HIV patients. So having the infection was effectively a death sentence in one way or another. Luckily, since the late 80s, the 90s, we have drugs that work against viruses. And we don't have just one or two, we have a whole, list of these drugs, anti-retrovirals. So let's talk a little bit about some of the main ways that they work. So if we start on this diagram, we've got number one, binding. There's some drugs called CCR5 antagonists. They actually prevent the virus from binding onto host cells. If they can't get inside, they can't replicate. That's how that works. There's fusion inhibitors, which do a very similar mechanism. They stop the virus from fusing with the host cell. And some of the most important and widely used antiretrovirals are these reverse transcriptase inhibitors. We won't go into the details of how they work exactly, but they target this unique viral enzyme, reverse transcriptase, and prevents it from creating DNA from the viral RNA. And if you imagine that it's that process which reverse transcriptase does, it's a bit like a zip, doing up a zip. So you have one zipper or one side of the zip, and the enzyme is essentially the zipper. And as it moves along, it's adding on individual nucleotides to create this double-stranded DNA. And in one way or another, they effectively cause the zipper to stop working or for the zipper to get stuck. And if it can't move on, the viral life cycle, it's interrupted. There's integrase inhibitors. We've talked about that enzyme integrase as well. And number 7 there, protease inhibitors. So once the virus has used the host cell machinery to make a really big molecule, this molecule needs to be cut up in order to become useful for the virus, viral proteins. So by stopping the chopping up of this very long protein, these virus particles don't bud off. They're not infectious. So luckily we have all of these different drugs, and that's really important because on the top right of the screen here, this is from one patient. It's it's all the variation of one virus. So viruses mutate really quickly because they don't have mechanisms to proofread their RNA or their DNA. So they mutate so quickly and they can become resistant to just one medication. And that's why nowadays people take 3, 4, sometimes even more drugs to deal with these infections because they work in different ways, they work better, and they stop the virus becoming resistant. So let's get started on a cocktail of these drugs. Let's say 3 or 4 of these drugs, and his white cell count starts to go back up. So now he's not having to deal with weird infections. And a year on, he gets another blood test, and it actually shows that his viral count is undetectable. That's really important because it means he's no longer infectious. He can't pass on HIV. So S will be taking these drugs for the rest of his life to prevent the HIV from coming back. But these drugs are incredible because they've turned what was effectively a death sentence into something which people can live with and live very well with. There we go, all finished. Thank you so much for listening. I hope you've taken away from this session a little bit about HIV on a molecular level, what it looks like, this virus, what the life cycle is, and which drugs target which parts of the life cycle, and maybe what that looks like a bit actually in real life, in the clinic, in practice. So I hope you enjoyed, and until the next time.